All right. Hello. We are kicking off our conversation around denials. So thank you all for being here. I'm going to jump straight into the presentation. By way of introduction, I'm Doug Kimball. I'm the head of marketing here at Red Sky Health, and I'm hoping that you are seeing our screens. But we've asked you here to give you a chance to learn more about what it is that Red Sky Health is doing, how we are helping to resolve the claims denial challenges that so many healthcare providers out there are facing by using artificial intelligence, machine learning, the innovative technologies that make a difference for the process of improving denials. So to cover what we're going to be going over today at a high level, we have four big buckets. We want to talk through some of the what's going on in the industry. We are hearing a lot about post-service denial rates. It's taking a long time to get denied claims fixed. We're seeing a lot of problems with staff changes, staff attrition, billing changes. There's a lot of regulations that keep being brought in and changing. All the changes with Medicare, as an example, Medicaid, constant changes to insurance policies and the updates, and trying to keep up to date with those is a challenge. However, we want to use AI as part of our advantage, and that's what we're doing behind the scenes. We've got very advanced algorithms using machine learning and large language model to identify the patterns within these denied claims, looking at historical data so we can predict and then correct those denials proactively in real time. We'll share a quick success story about how our platform is helping our clients right now as we are live. Right now, identifying the issue, providing those real-time fixes, and automatically resubmitting those so we can get providers paid. And then we'll wrap up with what's the future? We want to focus mainly on what we're doing right now, which is improving the denied claims issue. But because of all the things we're doing, we can bring in more options for advanced patient care. So let's jump in. Let's set the stage a little bit. Claims denials, and if you're watching this and you're in healthcare, I'm hoping that you're nodding your head and saying, yes, this is a problem for us, our problems we're hearing about. 3 out of 4 healthcare providers say that denials are increasing. So instead of getting better, the problem only continues to get worse. And this is a serious challenge for healthcare and for the patients that they're dealing with. A survey from Optum, I think it was 2024, the Revenue Cycle Denials Index said 84% of claims denials were potentially avoidable. That's a huge number. It's a huge also risk of revenue loss and also risk of personnel spending time on things they shouldn't be doing. And while it's not something we directly fix, looking at this, it was a study from I think the 2023 KFF's survey of consumer experiences. 39% of those who had trouble paying their medical bills said the denied claims contributed to their financial difficulties. We want to be a provider that can help make life better for the patients that are dealing with this. Obviously, we're focusing on healthcare, but the end result is we want to try to drive opportunities for improvement in the overall care cycle. A little more detail on some of the why behind this. This was another survey done that HFMA did. Why did you increase full-time employees that are involved in billing over the last 3 years? And the biggest one was in managing insurance denials. That's a huge one there. The second one, and this is where you're struggling, I'm sure, is following up on all those accounts receivable. You're having to go out and chase after the cash that you're owed for the payments of the work that you've done. And unfortunately, really low next to that is handling patient questions. So if you really, again, we want to focus on improving things for our ultimate goal is taking care of the patients. So with it costing roughly $48 to rework a Medicare Advantage denial and almost $64 to rework a single commercial denial, there is a huge administrative cost that we are seeing our providers experiencing as they rework these claims every year. So $20 billion problem. So in short, the current denial process right now does not work. It's very labor intensive. There's a whole swivel chair mentality going back and forth, looking at a claim, finding the answer for, resubmitting it, hoping it works, hoping it's the right code. There's not a lot of automated tools that are really helping this process. And sometimes we hear that some of these denials, providers are just saying, I don't have the time or the interest or your ability to get to that. And so one of the surveys we've also come back and seen is almost 20% of all claims are denied, and up to 60% of those return denied claims are never resubmitted. And my colleague Jay will be taking over in a second. He's got a nice twist on this, but it's very important to understand that's a huge number of missing cash, is the best way I can say that. And so that's what we're here for, is we've developed a advanced system using all the historical data, using AI machine learning that goes through, looks at that data, looks at and analyzes that, and then provides recommended actions to fix those denied claims and then also improve those payment outcomes. And not only does it provide the actions, it can automatically resubmit those. So the process basically becomes hands off. And so there's two main challenges that are part of this. What needs to be changed? Was the code missent in? Was it put in the wrong order? All those different things. And so once we identify the challenge, we need to understand what do we change it to, which is the to. And that's what we're solving for with our platform that we call Daniel, which is a play on the word denial. And with that, I'm going to turn it over to my colleague Jay, who will take it from there.
Thank you, Doug. Okay, let me start off by first introducing myself. My name is Jay Pillai. I spent about the last 20 years or so working for health insurance companies, and I used to run the operations department. I used to be with Wellcare Health Plans based up in Tampa, Florida, now Centene. I was the COO of the government program division of Blue Cross Blue Shield of New Jersey, and then lately the COO of CareSource. Now, what excited me about this opportunity was here was an organization with a vision. How do you remediate claims without human intervention? And having attended innumerable number of joint operating council meetings with providers, with hospitals, this is a real problem. I know Doug talked about 60% of claims not being resubmitted. There's a lot of debate. Is that 60%? Is that 30%? Is that 20%? But the fact of the matter is this. Ultimately, the claim is not paid by the insurance company, and either a patient or a provider bears the burden of that. So the goal is quite simply ensuring that we get our providers paid for what services that they have been rendered. With that, let's talk about what Daniel does. Daniel really identifies the root cause of an issue as it relates to a claim for a service rendered, remediates the issue on a real-time basis, followed by resubmission of that claim. The accuracy is greater than 95%. So this is really important. There is not a single organization out there that can do this on a real-time basis. And Daniel, as Doug pointed out, leverages advanced machine learning and generative AI algorithms. The inputs to Daniel are really historic ANSI 5010, X12, 837s and 835s. 837s, as most of you know, are simply the encounters between a patient or a member and the doctor. And the 835s are really the remittance advices that come back from the insurance company that points to whether the claim was paid, denied, or partially paid. So what you're going to see in the next several slides are how Daniel works, how it fits into the overall process, the impact of Daniel, a testimonial from a customer, and results. With that, let's move on to the next slide. There are really 4 steps, very specific to how Daniel performs its real-time fix. Step 1 is pattern recognition. Now, what do I mean by this? By looking at the historic payment denial patterns by payer, it stores within its memory exactly how a different payer either pays a claim or reimburses a claim with very specific CPT codes and the correlation between diagnosis codes, modifiers. And I think it's no surprise. Contracts, but most provider groups, payers contract with all of them. If you take any particular zip code, if you look at a United or a Blue Cross or a Centene, they contract with literally every provider. But now providers see members with similar risk profiles within a particular zip. And not surprisingly, you've seen publications like from the Kaiser Family Foundation that points out to varying denial rates by insurance companies. And that should clearly tell you that there is a distinction between how different payers reimburse providers. So having that understanding, having a model do that, as opposed to having an individual who retains that knowledge, and that person becomes a specialist knowing how to process United claims or Centene's claims or Blue Cross claims, That's just not going to work in the long term, particularly when you have turnover, or if someone does not show up to work a particular day, you could have all kinds of issues. And you're relying on the memory of an individual to actually perform that task. So these base models leverage these payment denial patterns of these individual payers by the particular line of business. It could be Medicare, it could be Medicaid, it could be the Affordable Care Act, it could be based on commercial payment schemes. So it could be based on different contractual arrangements. It also takes into consideration a provider billing pattern and also the patient history. So if there are diagnosis code that is on a patient's claim, and if that history of that claim is in our database, the algorithm can actually go back and track that as well. So in the event you've got a procedure code, diagnosis code mismatch, and you recognize the fact that that diagnosis code was on a previous claim, very specific to that member, it can make a recommendation as to add that. It can change the order of the diagnosis codes. So you can see why having those historical claims is really a benefit. While it's not a mandate, you don't absolutely need it in all situations, having that is always a huge plus. Now, once you have that information, the second part of it is really the analysis phase. The analysis phase is really where the root cause is identified. And there are a lot of other companies who can do this, right? Because essentially each claim that's denied has got a denial reason code, a CARC and a RARC. So based on that, you can identify as to why something failed. But the more important part is, what do you need to fix to get it paid, right? Getting that done programmatically, which is really the third piece of it, which is the recommendation phase. So what the algorithm now does is it looks into opportunities to maximize the probability of payment. And what we've done is we've contextualized CCI edits, LCDs and NCDs, payer-specific reimbursement policies, state Medicaid guidelines, AMA guidance. So we've actually codified some of these, not through business rules, contextualizes using generative AI. And as these run through, it actually makes recommendations. And then the last phase of it, step 4, is the validation phase. In the validation phase, it actually looks at historic claims of that patient to actually do a check. Have claims for that specific payer with this specific member or patient for these set of conditions paid before. And more often than not, you tend to see the same CPT code, same set of diagnosis code where it has been paid. And in the event it's not member specific, we move down to a community pool using a cut down logic, and we try to arrive at a scoring mechanism that actually provides a confidence score that tells you the confidence at which that claim is going to be paid. That's really truly the basis of that 96%. Now, in every new engagement, there is a manual review of the model's predictions. 100% of claims are reviewed, after which we release it into a stream where it goes directly as recommendations to the client, or we resubmit the claim if that's what the contract requires us to do. Then the last step is really the optimization of the model. This is just as important because we want to be sure the model is indeed performing for what it was designed for. The inputs that go into the model cannot be far off from what we have designed the model for. So if the model is really heavily fine-tuned for primary care physicians, and if you're actually going to submit something that is perhaps tied to just purely specialists, then we could have a mismatch. So we make sure that the model is trained and there is no biases, there is no drifts in the model, that's continually fine-tuned, continually monitored on a monthly basis. Next slide, we're going to talk a little bit about how it fits into the overall process. So we start off where a patient or a member sees a provider. So as a result of that meeting, a treatment is rendered based on a set of diagnosis codes, and you create a record, a transaction, an encounter, i.e. a claim. An 837 or a claim is submitted by the provider through a clearinghouse to the insurance company. Now, the insurance company can either pay the claim, deny the claim, or partially pay the claim. That transaction is denoted through an 835. The 835 is submitted back to the clearinghouse to the provider. Now, Red Sky in its contract with providers will get a copy of both the 837 and the 835. In fact, we receive all of those. In the event we see that it's a denial or a partial payment or a partial denial or a partial payment, we would essentially analyze it, leveraging what we talked about in the previous slide. And based on the recommendations that have been validated, we would essentially create a corrected claim if our contracts say so with the frequency code 7. We resubmit that clearing claim through the clearinghouse. We have contracted with the clearinghouse. We resubmit through the clearinghouse, goes back to the insurance company. The insurance company adjudicates the claim, and we expect it to be paid this time based on the confidence we've got. Then that payment actually goes back to the clearinghouse, to the provider, and we validate the payment through the 835 that we receive. That summarizes the entire life cycle of a partially paid or a denied claim. Now let's move on to the next slide. So what's the impact of all of this? Now, if I can bring you back to what Doug talked about, the current process is really labor intensive. 100% of claims or denials are not necessarily processed or resubmitted all the time. There is a high attrition. You rely on domain knowledge of very specific individuals, specific to insurance companies or payers. There is a cost associated with it. And lastly, it's never timely. Now, when you look at what Daniel does, it guarantees that your claims are paid timely, accurately, consistently, at a lower operational cost, and you get cash in the door faster. And ultimately, by doing this, the beneficiaries are patients. Our providers get to spend more time with our members, our patients, and that's truly where care belongs. That's what population health is all about. So we can spend more time focusing on preventative care as opposed to urgent care, or have situations where patients come in only when there is a need, as opposed to making sure they get the right care at the right time early so they can avoid ED visits, urgent care visits. Okay, now let's talk about a client testimonial. I'm going to pause for perhaps 15 seconds, so I'll give all of you a chance to read what's on that slide. And I think most of you can see that we've got a 40% increase in overall revenue and a significant amount of personnel hours, right? Two of the key items I just talked about in the preceding slide: increase in revenue, significant amount of personnel hours, i.e. this means at a lower cost, increased revenue, and I'm sure it came in much faster as well. So really cash in the door a lot quicker. Okay, moving on to the next slide. What does this mean in terms of metrics? This is based on our current engagement with 90 plus providers that we have. 65% reduction in denials. And this is truly on a real-time basis. Now, this number varies by provider depending on the denials. But if you look at denials in general, there are really 4 or 5 different buckets. Bucket 1, type of changes or denials that are tied to modifier, place of service, diagnosis codes, reordering of diagnosis codes, CPT code diagnosis mismatch, so it's CPT codes, or it's a combination of one of those. That would be one bucket. For this bucket, we've got real-time fixes. The second bucket could be eligibility issues. On scenarios like that, we've got an insurance discovery algorithm, but what we also substantiate that with is algorithms internally to check if it's primary, secondary, if you've got a previous claim that was paid by a different payer. We are also connected to ancillary services. We've got 270, 271 services where we can check the status of an insurance for that specific data service, and we could essentially recommend the right payer so as to get the claim reimbursed as well. So that's the eligibility bucket. So not every time will you get a real-time response, and that brings that overall percentage down. And then you've got a third bucket that could be tied to scenarios where someone forgot to include a clear number on the claim, and you have an authorization in place, but you didn't include the auth number on the claim. So being able to make that recommendation, but ultimately to get that claim paid, you've got to get that and insert it onto the claim before you resubmit it. And then the last it says, truly, when you're talking about scenarios which is appeals-based, i.e., you did not get an authorization, or you perhaps build a 99215 and you get, a denial saying that, hey, you probably did not meet medical necessity, so we've got to submit medical records. That's the bucket. So it could be a combination of that. So when you look at that in its aggregate, about 65% we have leveraged using Daniel to submit on a real-time basis. Now, that's the model that we've got, and our reimbursement model is tied to one where it's a percentage of what we recover. And again, we work very closely with our clients to make sure that they are truly seeing the benefit from this product as we move forward. Okay, moving on to the next slide.
Before we move on to that slide, there was a question that came in. I wanted to have that talked to about before we finish up the next slide. So Jay, there's a question that came in. Thank you. Somebody said this is incredible, so we always like hearing that. Are there data in addition to 835 and 837 integration needs that you have to have from the provider and insurance company to implement Daniel? So where is the training data sourced from?
No, so we use our historic data to actually perform the training of the model. Purely, all you need is 835 and 837. Exactly what is submitted to the insurance company, the 837s, the 835s that come back, that's all you need. That would be the feed into the model. Now, based on what the model responds to as an output derived by the CARCs and RARCs, there may be a recommendation that says you need a clear, or you need something else, or medical records in events like that. Or you could have a scenario where we may say, add a CPT code, a different CPT code, or change a CPT code to a lower level code. Now, the bill dollars are going to change. In scenarios like that, there would need to be some input from the provider, unless we've got a master list that captures all the bill charges. Hopefully that answered the question.
Yep.
Okay, now just to wrap it up, given that we've got historic data, what else can we do with the data that was going to enhance or provide a value add to our providers? So I've talked about what you see. I'm going to go in a counterclockwise direction. We've talked about denials. So I'm going to talk about this, what you see at item number 2, which is revenue generation. What I'm truly talking about here is a form of population health. When you start looking at patients who may have one or more chronic diseases, or who may have been just discharged from a hospital, right? Codes like 99490 for chronic care management, or principal care management codes 99294 through 297, or it could be behavioral health integration 99484, or it could be when you get discharged, it could be a transition of care, and that's also a STAR measure, right? So if you see your primary care physician or a doctor within the first 7 days with the 99496, the odds of them getting readmitted is substantially lower. So being able to identify those scenarios, leveraging the data that we have plus ADT data is really very, very critical. Or something as simple as wellness visits, a GO438 or a GO439. We can recognize the fact that, oops, it's time for that patient to get a wellness visit. Being able to point that out to the provider so they can assess or have their office schedule those appointments and getting the members in and focus really more on preventative health is really the objective. Another way to look at it, if you look at the lower right, it's care gap closures. If it's Medicare Advantage plans, we detail there colonoscopies, mammograms. It could also be readmissions. It could be diabetes care for the eye or for blood sugar or colorectal cancer. It could be any one of those measures, right? This is talking about Medicare. If it's Medicaid, given that I spend a lot of time in Medicaid health plans, a percentage of the premium that health plans receive is actually kept back by the state and paid out based on hitting certain quality metrics. And those quality metrics in most states for Medicaid are tied to preventative care, maternal care, child care, and you've also got behavioral health quality metrics as well. So If we have a line of sight into what those measures are, we could essentially provide wonderful insight into who those members are. So from a population health perspective, it would essentially be excellent feedback to the docs so they can bring these members in. It's a value add to the health plans. It's a win-win on both sides of the situation, of the equation. They would get their premiums and the docs get the benefit of added revenues as well. And then the last piece is on the upper right is contracting/auditing. We can leverage our AI to look at trends. Are some providers billing excess 99215, so 214s versus others who are not billing enough? So being able to point some of those out, that's one part of it. The other part of the equation is also being able to suggest negotiation strategies based on some of the trends we see on a pricing perspective without divulging any of the confidential information as well. So really, by virtue of the fact that we have the data, we may be able to implement approaches that would essentially provide insight into how that data can be used to bring your members in to focus on population health, essentially a way of redeploying some of the resources that perhaps have been used for other purposes on denials. Doug, I think we may have, we are at the end of our session specific to the slides.
That is it. And yeah, and Jay, I appreciate the feedback and the presentation. And I believe I mentioned in the chat window, please, if you have questions and or thoughts or feedback, we'd love to hear from you. So I'll get a few minutes before we wrap up the conversation. Please continue to put your questions in the chat. Also, if you aren't following us on LinkedIn, we definitely encourage you to do so. If you have questions after this that you are thinking about, or you want to learn more about Red Sky Health, please reach out. You can either email Jay, J-A-Y, at redskyhealth.com, or our head of sales, Ted, at redskyhealth.com. We'd love to talk with you. Now, there's a lot more we can show under the covers with this from a demo standpoint. It's a very easy process to get started and a lot of great ways to save revenue and drive patient outcomes.